Hi, Stephen. Hi, John. Welcome.
Thank you, John. Great presentation. I was wondering if you would entertain a question just in regards to engaging employers. One concept would be the idea that a network could be an IPA or an independent physician organization. I'm kind of shocked that this hasn't occurred organically in the DPC movement. Maybe it's like herding cats, but that would be a very efficient way to organize DPC physicians and help prevent restraint of trade by using like a messenger model. Do you know of anyone who is trying to organize a national DPC IPA?
Caveat, I'm not a provider contracting expert or organization experts because your legal entities are crazy as clinicians to me, like MSOs and IPAs, and I'm a corporate attorney by background too. So that's my caveat on my answer. The answer is yes, there are lots of people that are working on various national approaches to it. I've seen ones using MSOs. I've seen ones using like just a contractual network where it's not that. IPAs are governed pretty uniquely by states, and so are MSOs. So there can be some like legal challenges of how you actually put them all together. Oh, just legal work of how you put them all together. So I don't know if anyone's doing IPAs.
I mean, the value to the physicians would be, it would be a collective, it'd be a cooperative that's owned by the physicians, as opposed to a network where then the DPC groups become commodities, you know. And so I think DPC physicians feel more empowered if they have their own IPA. But that's just me. I mean, I've been part of IPAs in the past. We aren't now.
Yeah.
But it helped prevent collusion and price fixing allegations that, you know, right now we're pretty immune to, but in the future we could see those kind of challenges, particularly from folks not happy about DPC, whether it be hospital systems or large major payers.
Whether they're technically using an IPA or if they're just using like an MSO structure, I'm not 100% sure. I haven't ever asked in that level of detail. The other thing I've seen is some ACOs emerging, some ACO structures. And so they're kind of integrating the clinical and financial risk together. And depends on how broad of a definition you want to call DPC, you want to give DPC. We don't have opinions on it really, but I know a lot of physicians have very, very strong opinions.
Excellent.
Do you have, as you put Mr. Head back together, do you have some physicians or physician organizations taking more risk, more global risk beyond just the, in effect, what in the old days we'd call capitated risk for the primary care services?
Yes. I will say, so in the chaos of like primary care renaissance that we've got of like all these different versions going on, I'll say most of the organizations are coming from the not pure DPC level down. They're coming from like the like a Privia or someone like that, where they're kind of like a next generation practice management type firm, and they're contracting with provider or with carriers, and they're fully capitated, things like that. Iora Health's done stuff like this, but they tend to be coming from the Medicare Advantage world or the kind of like next generation practice management, like Catalyst in Dallas or Privia or players like that. On the DPC side up, we've seen some like the more common approach we see is some sort of like simple gain sharing type things where the parties all agree to like, okay, these are the types of downstream care that are directly affected by primary care, and we're going to have some sort of like avoidable ER visits or reduction in inpatient. I think a big thing that direct primary care could do that would be big for employers is site of care issues, because then like I see a lot of ROI models on these like, and a lot of potential risk around like avoidance of care of things not happening at all. And mathematically, it's just hard to prove negatives when it's more from a population level. Unless you're a gigantic employer, almost everything that happens that's costly is more attributable to statistical noise than it is to actually done. Like if you have 500 employees, you have 1 year, you have 10 ER visits, and another you have 5 ER visits. with nothing changing. And so what we've generally seen on the DPC side is a much more constrained, defined like gain sharing agreement where we say, okay, like site of care optimization, like, okay, we know that knee procedures, absent some sort of uniquely complex patient, can happen in ASCs and should happen in ASCs. So things like that of like this knee surgery that did happen last year happened in an ASC, we engage with the member to help make them do that. And that could cut the cost down from $60,000 to $20,000. So that's a little bit broader answer than what you're asking, but most of the full capitation we've seen is coming from MA down, really, especially if you're talking global cap. Like if you're talking like full on like global capitation, it's all been that.
Yeah, that's MA, right?
But then we've seen other versions of primary care capitation that would go broad, are more broadly defined than what you would see as like pure DPC services that you provide directly.
And sorry to ask such a basic question, but could you give some basic fun facts about your organization? How, you picked them. How big, locations, members, however you would define fun facts.
How about how small? So Health Rosetta is only 9, soon to be 10 full-time employees, and then a number of part-time people. Because we work on this very decentralized basis, we have 217 advisors, Health Rosetta advisors, in our program that represent like 5 million lives or so around the country. And basically we enable them. We also started launching programs with TPAs and things this year and underwriters and stuff like that. So how small our actual organization is, given how much yelling into the internet about us there is by people, is probably one of our proudest accomplishments generally, but we're very small. Fun fact too, Linan, who's the main event manager for Hint Summit this year, is our main event manager as well. So we share teams, and part of the reason Hint Summit's so awesome this year is because of Linan and her team. And then third fun fact is that no one on Health Rosetta's team works in the same place, even pre-COVID. We all work in separate areas.
How many flow through this to DPC physicians?
So we don't, that's the decentral, we don't measure every single thing that every single advisor is doing. Sometimes we're educating them.
I see.
But it's in the tens of thousands, if not more.
That's great. Well, thank you. I'll let other people come in here, and thank you very much.
Just a quick question on the health sharing network and that sort of rise in that and how that fits into Health Rosetta and advisors. And can you just talk about that a little bit for me? So like health sharing plans type concept? Like Sedera, and how does that fit into what you do? And it's another issue of that, what I was saying in my presentation about it's the bag of it's the funding mechanism of what it goes into. There are pros and cons in a lot of legal complex. So generally we're a fan of every funding mechanism that gives the flexibility to do these things within the plans. There is a wide range of health sharing organizations that are flat out illegal to very compliant and very good. And there's a lot of, especially at the federal level, there's a lot of uncertainty around certain elements of these as far as what regulatory bucket do they sit under, and legally how do they exist. So in our world, we basically tell our advisors that they just need to make sure their employers understand it. And the same thing with the expansion of the association health plans. In a lot of cases, what we've seen is employers tend to lean towards what are called captives, if you're familiar with those, as a more comfortable risk mechanism for groups that are large enough to be in that, which would be like 50 and up-ish, maybe down to 25. That is one of the challenges, is the structure for things under 50 is there's not a lot out there, and the health sharing organizations have done a really, really good job at filling in that gap. And the ones that do it compliantly, like Sedera and others, are we're big fans of. I see. That answers your question. We can talk like technicalities if you want on this stuff, but I don't know how deep of an answer you want on that. No, that was great.
Okay. Here, I'll just mention that both Sedera and Zion to assist in sign-up flow between those organizations and DPCs. Sean, I have one more question for you based on the chat from the last session, if you can answer in 4 minutes before we go over to Zach's keynote. Can you describe the difference between paying a broker on a per member per month or per employee per month basis versus how Health Rosetta brokers are paid, and how DPCs can understand kind of the very basics of broker commissions as they get into relationships with brokers and advisors?
Ooh, fun. Short version is, so Health Rosetta, we don't require everyone to get paid a certain way. We require them to disclose every way in which they get paid. And the reason why is that the compensation market in the broker world is highly complex for various reasons. And we generally encourage Health Rosetta advisors to be fee-based and either per employee per month or a flat retainer or some other model, because then your clients pay you, they know why you're paying them, you're treated as a consultant, you're not like a product pusher. And that would be a big thing to ask brokers, is how do they get paid themselves from their clients? And then if you're a DPC provider paying brokers, I know on your side of the world, on the clinical side of the world, you have all sorts of issues with how you can pay people and whether you should. I would generally, even if it's a Health Rosetta advisor doing saying to you, which might happen, there's 217 of them, I don't know how everyone's going to act in every scenario. Don't pay PEPMs to brokers to push your product, to push you. I just wouldn't do it. I mean, I know it gets more common, but there's a lot of pitfalls in that. I'm trying to keep in the 4 minutes on this. Is there something specifically within that you want me to go into a little bit more depth on, Beth?
No, I do think we have DPCs who are in relationships with brokers who are being paid PMPM, and they see it as a way for them to outsource some of their kind of marketing and patient acquisition. But I just wanted you to kind of hit that high level of the broad range of how brokers are paid. And if you could just talk a little bit to like how brokers are maybe incentivized to recommend certain things based on the way that they're paid.
So first thing, based on what Beth was just saying, don't pay commissions at all. Like, just don't. There's challenges for you as a physician organization. There's challenges from the broker, from the Department of Insurance. And that's in each state. Brokers are regulated by the state Department of Insurance. That's who they get licensed through, that sort of stuff. And paying them commissions for non-insurance products is not a good idea. Now, paying them a PEPM sort of feels like form over substance, but for whatever reason, everyone's cool with that around the country. And it's not particularly risky or anything. How they get paid generally depends on the market. Very fully insured broker, they get paid commissions by carriers, and they get paid direct commissions for placing business, and they get paid indirect compensation. Like if you hit certain bonus or certain levels of production or retention bonuses, they're called overrides or non-account specific compensation. And they are deeply not disclosed generally in the market and create lots of stuff. So in the broker world, in the fully insured world, basically brokers are treated like buyer's agents by their clients or by their employers, but they're paid like seller's agents, which is sort of weird. And it's illegal in the capital markets. So from my perspective, it's really bad practice, but in the finance world. And then in the self-funded world, it's a little bit more balanced nowadays, where people get paid fees and they might also get paid back end, and typically they do. They'll get paid per prescription. They'll get paid these compensation bonuses, the same overrides, retention bonuses, things like that on top of it. But the initial, like, what you get paid isn't so much seen as a commission anymore. It's like a PEPM, and that's pretty typical for any broker. And the bigger the firm the broker's at, the more likely it is to be like that on the front end. Hopefully that answers. It's all over the map.
Yeah, it's complicated, and DPC should ask. Thank you.